Hopefully Dr. Espinosa will show up soon. Because people are just going to be wondering what's going on. So I'll just do this until he arrives.
Hi!
Anyone who's watching online wondering what's going on?
I have a good idea.
Yeah, she's like between 20 and 30 dialysis centers a week. So you know, seeing several different dialysis centers. And she explains.
Goes like 2 hours of time.
He goes there?
Oh.
What?
Yeah, it blows her mind.
Wait, it's lagging. It's lagging.
Yeah.
There it
goes.
So, I mean, I can put the schedule out.
Oh, it does it again!
He does like a teaching topic every day. So.
How many times do
Here, put your hand on that side, because then it'll start the wave on that side.
Where?
Just put it in front of the screen over there. Yeah, there you
So
go.
basically how it works. Like
See, my hand keeps going into the next screen. In and in and in.
There you go.
Watch it.
I would say it's
Watch
probably
it.
the worst.
There it goes.
There it goes.
What are you guys? Oh my gosh.
Wherever. Castception.
Huh?
So, did you ever get an answer to if you're allowed to write notes underneath this username and password?
I was to see if it would reflect, but it didn't.
Was I supposed to ask
Sure.
What were you guys told? Last year?
Do we have,
No.
we have the dealia for the apple? Can you turn on the apple? Whose is this?
This is the weirdest song I've ever
Is this our? There. What is this?
That's the film, yeah.
Who's in? Huh? Hi.
We just look like a walk racing. Have you ever seen that?
Who made Espinosa with the S?
So stupid. Espinosa.
Yo no soy Espinosa, soy
I didn't do it.
Espinosa.
Whatever. No, I'm just
Zero.
figuring it out myself.
Gotcha.
Okay, so this is broadcasting, but I need my computer. Oh,
Shit, you mean totally screwed.
I would agree with that.
Maybe not. Nutritionally, if I end up being one of
I guess.
So Ben had to go. You restarted Hiatus? Oh, okay, good. I was like, she should have
She's
followed
only in seventh grade.
Must be a 15.
I had somebody reading there in the day.
Do you need help? I'm okay with saying that, but do you need
Doing what?
No, so, yeah. Just let me know. She's got like a couple of little cards and stuff.
Yeah.
Okay.
Yeah.
Those, that might be good. Lunch first, though. Really want to get some lunch.
Oh, that's perfect. Thank you.
I just had pancakes for lunch.
And she's coming with you to Stop Box, right?
Nice.
But it's just.
That's why
Okay. Oh, gotcha.
Benjamin, can I ask you a question? Okay, so this is my deal. It's still loading. Can I put it in?
Where?
What you mean?
Yeah, but where it might,
Nothing there.
yeah, but
arrow.
where it might, where it might do like my notes somewhere else.
I think you could do presenter view.
Probably.
And then you would just drag. You would drag. I think you drag the other thing. I think you drag the other thing over there.
It's made big bucks for this.
Oh,
I'm not really sure how to handle.
speaker notes.
Yeah.
That's right.
So you leave this one on your screen, you drag that one on the other, the whole thing. And then you're gonna click the full screen, this little cross.
So then I can come back over here. Ah, okay. Okay, sorry guys. Clinic was crazy. Since we don't have very much time, because interns have to, or there's people who are going to clinic, I'm assuming, in the afternoon. Okay, so this is very much kind of, since we're just now starting to get into the lectures, I went through like very basics of stuff. I'm sorry if I'm going to offend probably you, right?
You've already done that.
Okay.
Long been done. Accomplished.
These are my beloved Razorbacks. Anyways, okay. So CT chest, what, when, where, how, who, kinds of things, and what kinds there is, kind of basic intern level. I'm not saying you guys, I'm just saying let's start. Let's make sure everybody is on the same page, okay? So CT scans of the chest, you know, there's an axial and a sagittal view. What is it? It's a bunch of X-ray pictures put together basically, and they produce a cross-sectional, which is the T part of the images. You can scan anything. They have CT scanners. Obviously, we know them for medicine, but they have CT scanners for like big, huge 18-wheelers that come through the border of Mexico to make sure that they don't have drugs inside. That's kind of interesting. When do we usually order these? Usually when we when we want further evaluation. When we're concerned for pulmonary embolism, when we're concerned for the extent of the disease in the lung parenchyma, when there's trauma to the chest that we need to evaluate, aortic aneurysms. So usually we do an ultrasound for a AAA, but if it's in the chest, you need to do CT. And then anytime there's like a lung mass that you have that, we don't deal with these very much, but whenever there's a lung mass that needs to be evaluated and you need to plan for surgery, then that's, you know, obviously these are not all there's many more. But the reason why I picked this is because if for a PE, you need a CTA. For a lung parenchymal disease, you need a CT scan without contrast. For a trauma to the chest, you need it with and without contrast. For the aortic aneurysm, you definitely needed that. And then anyway, so there's just different kinds of CT scans that we can do. If you do not know this, I did not know, I learned it in my first month of intern year. The American College of Radiologists has an appropriateness criteria, and let's see what happens if I do that. And so it looks like this, and it basically walks you through different scenarios of different diagnoses that you're trying to evaluate, whether it's the breast, whether it's the heart, whether it's the GI tract, whether it's musculoskeletal. Let's see, so thoracic. What's that first one? I can't read.
Acute chest pains.
Let's do pulmonary and.
It's the first one.
The first one.
Oh, it is. Okay. So then, then you go to the evidence table. This is really neat. I thought, and then it'll give you a score. No, that's the wrong one. Huh? Yeah. And so then it'll give you a score of what the diagnostic modalities that there are. So a chest X-ray is 9.
Yeah, you should automatically get that.
Okay, you should automatically get a chest X-ray for a suspected PE. But really, so the higher the score, the higher that's the one that's the most indicated, the diagnostic imaging indicated. So in this case, you would need a CTA chest with IV contrast. So this is the, I don't know, but it basically is kind of like a relative radiation, relative radiation level. Yeah. So so that's why chest X-ray is up there, because yeah, you should probably want to get that information, but then but this is the one that gives you the lowest radiation level compared to a CT scan, and that's really important to know. How much radiation are you putting the patient through? And you just, there's multiple things that you have to put in that equation in your head. There's not an equation per se, but you know, if it's a 90-year-old that you want to do a CT of the head because you want to, they just fell, want to figure out if they have a subdural hematoma or not, then you just go ahead and do it. If it's a little baby that you're trying to figure out if they were born with an aneurysm, or do they have a brain bleed anyways, then you definitely don't go for that. You go for the ultrasound because they still have the fontanelles open, right? So that's what this website will do for you. It's actually really, really good. They're not all, that, straightforward like PE. Of course, you need a CTA, right? But this will help you out. We've pulled up this during rounds at times. Okay, so that's that. Oh, I already know. Picture. Blunt chest trauma, you need a chest X-ray, you need a chest with IV contrast, and without as well. So, but mainly, anyways, you're concerned about the cardiovascular system. So, obviously, at some point or another, you are going to order a CT scan on kids as well, only when it's completely appropriate, and that's why I said all patients at that point appropriate, because you are trying to keep in mind the kind of radiation that you're exposing the person to. Not only the whole body radiation, but also what kind of radiation you're putting that specific organ to. So a chest X-ray is just 0.1 to 0.15, but if you do a CT of the head, how many more folds is that? A lot. So definitely be aware of this. You want to be a good steward. You want to do no harm to the patient when you're trying to, even though the information that it's really needed, you might need to try to figure out a different way to use the tools that you have available to get all your information. The other thing is that you also have to be careful about how is that imaging or that lab going to change your management. If it's not going to change your management, then why do it? And then, you know, another curveball that you throw in there as far as being good stewards is a person a self-pay patient or not? And that's just a different thing, and it's a reality of our patient population. Oh shoot, I just messed them up. I just didn't want to run out of battery. Okay. So types of scan with, without CT angiogram, CT high resolution, which is pretty much what we do anymore, I think. And then there's now a cardiac CT, collimation, collimation, is the word that radiologists use to see, like, basically how thick they put in. There was a lot of equations and stuff that I was like thinking about using, but
There's also low dose helical CTs you can do for your.
Right. So so there's all kinds of stuff. Depends on how much information you're needing out of the images. So the collimation needed for a regular chest CT is at 2.5 millimeters for the mediastinum, and then 1.25 for the lung parenchyma, so that you can see really well. The high resolution ones bring you down to like 1.2, and then the cardiac CT, which is, they're actually doing this, they're slicing the heart basically in 0.25 millimeters, so it's like even smaller. And so some people are using this with contrast, and then that's your little like modified cardiac cath, basically. There's also a new screening tool that is not too popular yet, but it's like a CT colonoscopy, basically, that they look at. They'll look at the colon to see about nodules. Before you look at things that are abnormal, and this really just kind of takes time. Looking at lots and lots of CT scans, and of course a still picture doesn't really do it justice. But you need to know your anatomy cold when you go down all the way to the you know, not only the basics of left and right, but also when you're going down distally to the diaphragm or proximal to the lung apices. So because you're gonna have to use some sort of algorithm way to just kind of put yourself in like that way, in a way that you always look at a scan in that specific way. I used to like the ABCDs, airway, bones, cardiac, diaphragm, extra things for chest CT or for chest X-rays. But anyways, there's multiple ways to arrive at the information, but just as long as you're doing it in a specific way. I looked at this guy that did it this way, and I was trying to come up with a mnemonic that would come up with that, but was really difficult, and it was like 2 o'clock in the morning. But basically, you want to divide the chest into different anatomical sections. So you want to look at the lung parenchyma, because that's kind of, for the most part, what we're looking at. We're ordering a CT scan to figure out what's going in the lungs. And then you do this in a systematic way, trying to confirm normal anatomy, and then also looking kind of for the most common types of things. So looking for, not quit looking for the zebras kind of thing. And then so pleura, he moves it kind of outwardly and then kind of goes back into the airways. And I'll take a quick look at what all these, how you would go about this. So this is a non-contrast CT, which looks terrible on that screen. Is the modality that you want to use to look at lung parenchyma, to look at changes of basically chronic lung disease. The way that I've been taught, the way that I actually, this is why I picked that particular strategy, is because this guy would look at the CT scan. He would half the lung, okay? And so he would look at only a section of the right lung and go all the way up to the top and all the way down and look only and only there, because you're gonna want to try to avoid the tunnel vision. And I'm sure everybody saw the nodule, right? Especially because there's a line there. So, but the first thing that you look at is what's abnormal. But then, you know, sometimes the old dog has ticks, sometimes the old dog has fleas, but sometimes the old dog has ticks and fleas. So you might, so you might have that, but then you might be missing a huge lobar pneumonia on the other side, kind of thing. So you want to scan through the chest, looking at only this one, looking at the parenchyma, looking at how at the attenuation is the word of this part of the lung, and then you move on to the other four kind of halves. You want to try to look at increased attenuation in the lungs. Kind of comes up with like the ground glass opacities that you hear about, and those can be either like a consolidation of like a lobar pneumonia, or it could be chronic fibrosing of that part of the lung. If you have decreased attenuation, then you have emphysema, or that's kind of what emphysema will look like. So after you've done these four quadrants, you start looking for nodules in those same four quadrants. This is a picture of the lung fields, and this is on the lung view. Is this increased attenuation or decreased attenuation? Yeah, it's decreased attenuation. I don't care how, but just describe what's going on inside the lung field. Anybody?
Some of the spaces are getting bigger between the.
Yeah. So this usually happens towards the top of the lungs whenever you have advanced emphysema. It's called bullous emphysema. So that's what'll start happening. Sometimes these spots are as big as half the lung. So you just have to lung. And of course, you're probably not going to have great lung sounds over that area. So listening to the lungs is really important. You don't hear any rails, you don't hear any crackles, that might be a really good thing, but it also might be that person doesn't have any lungs in that part. So you have to hear what you hear, but also hear what you don't hear. right? Think about what you're not hearing. Okay. So this is an example of increased attenuation, and sure enough, this person has focal interstitial fibrosing, and so this picture sucks too, but you had decreased attenuation, so more of the dark spot. I guess I didn't go through that, but dark is air, white is fat, and even the whiter are the bones. So, and there's much more to that. But so here you're gonna have a semi kind of solid looking thing, but still it has intermediate attenuation. Oh shoot! Sorry, it's 154. So that's what a ground glass opacity means, and this person has focal fibrosing of that lung. You're still looking for the lungs field. So now we move from the lung parenchyma to look around to our border, to the pleura. And then obviously there's like this huge tunnel vision for these fluid-filled spots, and that's what a pleural effusion will look like on a CT scan. You also have to look at other things that aren't so. Sorry. That aren't so obvious, but they're still very, very important. You have to look at all of the pleura all the way around, and you can see on this pleura that it's kind of white on the top. That's called pleural calcification. And yeah, there's some thickening on the bottom too. Yeah. So this person has asbestos calcific plaques. So that's, sometimes we're just looking for that PE, but then we miss all this other stuff. Because I trust me, you'll just go right to the vessels.
You see the black or the plaques of the private eye?
Yeah.
Calcific.
Yeah, this is a calcific asbestos plaque. Yeah. But then this person also has kind of the thickening of the pleura here that is mostly seen right here. Yeah. So that's a more calcium atherosclerotic changes in the aorta. Pig. Don't worry, he made it better. He got better and beat the LSU Tigers, and we now have the boots forever. Forever. Yeah. This guy also moved on to the airway next. Obviously, it has to be midline. Everything has to be. It's coming out really, really, really terrible. You can't actually hardly see it. But this person has a foreign body right there, and it's moving everything that way. So again, we're getting an ultrasound because the person is dyspneic. Person is probably have peripheral edema. We know for fact this person has pulmonary edema, but then we miss, the airway. He just swallowed a big old ball or something. So kind of remember what the anatomy is, and in the anatomy there's also lymph nodes, and they're all the way up and down the trachea on both sides, and they also go down further into the bronchial tree. So that's kind of where you're going to try to look at for also increased lymphadenopathy, hilar adenopathy. And there are lymph nodes all the way up around the heart. There are lymph nodes under the heart. There's lymph nodes around the carina. And this is what this, this is more up top around aortic arch. But always make sure that you're looking for lymph nodes as well, because apparently over 1 centimeter is when you're wanting to try to figure out why is that going on. Does this person have non-Hodgkin's? Does this person have sarcoidosis, or any of the other things that make you have increased lymphadenopathy? And then also there are numerous vessels that I was gonna have all the interns name, but so you just gotta remember that those will be all throughout the lung, and you'll see them. You'll follow them all the way. And if you look frame by frame, and that's how radiologists look for pulmonary embolisms, because sometimes they're like really distal, small things, and then all of a sudden they stop. Sometimes you look at something and it looks like a PE, but it actually is a lymph node, and the way you know that is because you're scrolling through and you're not going to be able to follow that vessel all the way. It'll just show up and be in just a few slices. So the main time you're going to be using this as a primary care doctor is looking for pulmonary embolism. Then you also have to look at the heart and make sure that there's not too many things that you can do on the heart, especially on a non-contrast like this. But you can look at heart size. You can look at whether there's an effusion or not. And in this case, there is a huge pleural effusion all the way around the heart. And then you have to dig. Is it just a physiological pleural effusion? Is it is it blood? Is it water? Is it pus? And kind of go from there. And then just kind of the plain old bread and butter, using the CT scan to look at a terrible lobar pneumonia. And that's kind of what it'll look like. It'll look like a pie shape, a triangle shape going all the way to the end, because there's probably something here that started gonking up, and then it just made changes in that airfield. And then you can see the air bronchograms, because then he doesn't have mucus plugging yet, but this person's getting close to it. Anyways, that I had a couple of websites pulled up, but to look through them all, but it's 1 o'clock already, and I'm really, really sorry that I was late. I was just finishing up my patients. But just kind of some things to think about. Find the way that you want to be able to look at them. If it's ABCD through, great. If it's from the outside to go to the inside, from the inside to the outside, or are you gonna like this guy, just kind of divide the picture into anatomical sections that you can scroll through the entire way, and then move on to another anatomical space and through the entire time, and then another. That's why you see radiologists and you see Nelson going through, and you're like, stop! I can't see anything. But that's because they're seeing only one thing at a time. So that's I'm late, really fast lecture.
Thank you.
No problem.
One thing I learned that was really good is like in pregnant women. So pregnant women need imaging.
Yeah.
There's this thing called RADs that you look at.
That's right.
And so you can